Okay, so apparently we are now live streaming, which means we can get started. So these are things we're going to talk about, or at least I'm going to introduce, and then we can talk about a little bit later. And this is because many, many years ago, when I was a medical student, I was told by one of the lecturers that if you're ever discussing a disease, then the things you really ought to be able to talk about is a definition, the epidemiology of the disease, as in who gets it, the etiology, meaning what causes it, the pathology of the disease, meaning what does it do to the body, the symptoms of the condition, the complications of the condition, how you make the diagnosis, how you monitor it, and how you treat it. So I thought if we're going to give you an introduction to PBC, then those are the things that we should talk about this morning. So firstly, what is PBC? Well, as many of you will know, all of you hopefully will know, it is an autoimmune disease which affects the small bile ducts inside the liver. And because it affects the small bile ducts inside the liver, it is also known as a chronic cholestatic liver disease. Now, what do I mean by an autoimmune disease? Well, we all have an immune system, as hopefully you know. And that immune system is really there to protect us from infection. So it protects us from viruses such as the influenza virus or the SARS-CoV-2 virus that causes COVID. It protects us from bacteria such as E. coli, protects us from parasites and so on. So it's a very important part of the body. And it's a very well-designed system because it can distinguish between self and non-self. So it can distinguish between what is foreign, infections, infective organisms, and what is belongs to you, the host. In an autoimmune condition, the immune system, for inexplicable reasons, gets confused. It's no longer quite as good at distinguishing between self and non-self, and so it mistakenly begins to injure a part of your own body. And an example of a well-known example of an autoimmune condition would be rheumatoid arthritis, for example, where the immune system has begun to injure the joints. The other key example for this meeting is, of course, primary biliary cholangitis, where the immune system, for inexplicable reasons, has begun to injure the small bile ducts inside the liver. Now, you'll all know where your liver is. So your liver is located here, okay? And you'll know that one of your liver's main jobs is to produce bile, both as an excretory product, in the same way that your kidneys make urine, your liver makes bile, but also as an aid to digestion. Bile is very important for the digestion of fats. And that bile needs to get from the liver into the intestines. And the way that the bile gets from the liver into the intestines is through a system of drains. It's a drainage network, which is your biliary system. And PBC affects the very start of that drainage system, the very tiny small bile ducts right inside the liver, which you can only actually see under a microscope. And that damage, slowly but surely, causes all of the symptoms of PBC, but also eventually leads to cirrhosis. And we'll come on to those symptoms and complications in due course. So does that all make sense so far? Is that everything that you already know? Good. Next question is, well, who gets PBC? And the simple answer to that is that everyone can get PBC. Actually, it can affect adults of both sexes, of all races, of all ethnicities. It is, however, a rare disease. So you are rare and special people, all of you. And the way we define a rare disease is a condition that affects less than 1 in 2,000 people. The problem with a rare disease, of course, is that makes it much more tricky to study. So we know far less about why people get PBC than, for example, we know about why people get rheumatoid arthritis or inflammatory bowel disease, which are more common conditions. And the other problem with being a rare disease is that it makes it much more difficult to do clinical trials. And I'm sure some of the people involved in clinical trials will explain to you later just how challenging it can be and why it's so important to take part in clinical trials if you get that offer. Rates of PBC are highest in North America, in Europe, somewhere in between, lowest in the Asia-Pacific region. And you can see that highlighted on the maps there. So the lower map shows the prevalence of PBC, which is how many people have PBC at any moment in time. Dark blue means very high prevalence, lighter blue means low prevalence. So you can see highest prevalence in North America, lowest prevalence in China, according to this map. But the gray represents all of those regions where we have no idea. We have no clue as to how many people have got PBC in those areas. So, you know, so for a lot of the world, we simply don't know what the prevalence is and how many people are affected. And one of the jobs of the PBC Foundation is to reach out to all of those parts of the world so that those people are not left without information. Average age of diagnosis is around 65. As you'll gather just from looking around the room, PBC is much more common in women. Historically, we thought that that the rates were about 10 women to every 1 man. In fact, as more information is gathered, it doesn't look quite like that. It's probably about 5 women to every 1 man, but nevertheless more common in women. And one of the unusual observations is that the disease seems to present at an older age in men. When the disease appears to be more advanced. Now, we don't know exactly why that is. It might actually be that simply because there is this, gender difference, that physicians don't expect men to get it and therefore take longer to make the diagnosis. But that's something that can potentially be discussed in one of the breakout meetings tomorrow. And in places such as North America and Europe, it seems to affect the white population more than it does the non-white population. But again, this is not necessarily true. It might actually just be down to healthcare disparities, so that it's not really recognized in the non-white population. So that's who gets the condition. But, you know, in a sense, it doesn't really matter who gets it. If you've already got it, you want to know how it's going to affect you. Next topic that I just want to mention, and we can potentially talk about a bit later, is what causes it? Why do people get PBC? PBC is what's known as a complex disorder, which means that it results from an interaction of genetic factors and environmental factors. So what that means is that people have a genetic predisposition to getting it, but they need to be exposed to something in the environment before it's actually triggered. Does that make sense? And is that more or less what you've heard from other people? Yeah. Now, the evidence that we have that PBC has this genetic predisposition comes from simply asking people about their family history. So PBC, we know, is what's known as a heritable condition, which means that it can run in the family. And there will be many people in the room, probably, who do indeed have a family history. So it might be a mother or grandmother or an aunt who had PBC, or who had some other autoimmune condition. Okay, so PBC and autoimmunity, these are conditions that tend to run in the family. About 5% of people with PBC have a family history of the disease. And the relative risk in siblings, so in a sister, a brother or a sister, the relative risk is 10, which means that a brother or sister is 10 times more likely to get PBC than a member of the general population. The relative risk in the daughter of somebody who has PBC is 35. So the daughter of someone who has PBC is 35 times more likely to develop PBC than someone who was plucked out of the general population. Now, of course, that has led to many big studies to identify the genes that might be involved in causing PBC, and indeed many genes have been identified. No single gene causes PBC. It seems to be the cumulative effect of many genes, each of which has a subtle effect on the predisposition to the disease. And all of those genes that are involved in causing the disease are mostly involved in how the immune system functions. So, of course, this always prompts, in the clinic, this always prompts the question, well, if PBC runs in families, if there is this genetic predisposition to getting the condition, should my relatives be tested for PBC? And I can understand why that question arises. We've just said that the relative risk in daughters of a person with PBC is 35, so as I said before, the daughter of someone with PBC is 35 times more likely to get the condition than someone in the general population. But just to remind you what I said at the beginning, PBC is a rare disease. So if you multiply rare by 35, you're still left with pretty low likelihood of getting the disease. Furthermore, it's unclear whether there is genuinely any real advantage to a very early detection of the condition. Okay, so to give you an example, let's imagine that we screened a relative and we found that that relative had the antibody for PBC, the antimitochondrial antibody, but their liver tests were still normal. We actually wouldn't be able to offer them any treatment. All we would be able to do is to continue offering some form of monitoring whilst causing a great deal of anxiety and potentially affecting their insurance. So it's not obvious that there are any benefits to that extremely early detection. There are potential disadvantages, and therefore the current policy in guidelines is against screening of relatives. But it's something that we can discuss at the end. I mean, if that is something that concerns you, then write it down, and we'll discuss it at the end of the session. I said before that that PBC is this complex disease, so you need that genetic predisposition, and then you need the environmental trigger in order to cause the disease. So the next obvious question is, well, what are those environmental factors? Can they be avoided? Well, unfortunately, we don't have a really good grasp of what those environmental factors are. The disease is definitely more common in industrialized areas or heavily polluted areas. Unfortunately, there's not a great deal we can do about that in the industrialized world. It is strongly associated with cigarette smoking. So cigarette smoking is definitely to be avoided. And something else to mention is that cigarette smoking appears to be associated with more advanced disease at presentation and more rapid progression of the disease. So not only should we be telling people not to start smoking, but we should also be encouraging people with PBC to stop smoking if they are indeed smokers. It appears to be associated with recurrent urinary tract infections. Causality unknown. It could be that people with PBC are more likely to get the UTIs rather than the UTIs actually causing the disease. We don't know what the relationship is there. And it may be more common in people who use cosmetics. But again, this is a very weak association and very difficult to tease apart, given the fact that most people use cosmetics. Okay. All right, so what does PBC actually do to people? Well, if you look at the liver under the microscope, the liver of someone with PBC under the microscope, you will see this. That is what is known as a non-suppurative destructive cholangitis. And what you're actually looking at there is an inflamed bile duct. Okay, so it's a bile duct which is surrounded by lots and lots of immune cells, and those immune cells are damaging the bile duct. And that happens continuously over the course of many, 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 many years, such that without any treatment at all, PBC would eventually lead to cirrhosis. And that's the big problem, actually. If you didn't treat PBC over the course of decades, it would lead to cirrhosis and all the complications that come from cirrhosis. And that's why when we make a diagnosis of PBC, we want to get people onto treatment so that we can settle that inflammation down and we can prevent the cirrhosis from happening. All right, that's the ultimate aim of treatment. All right. Symptoms of PBC, of course, will be very well known to all of you in this room. Okay. Now, a good proportion of people with PBC actually have no symptoms at all. That's good. That in those cases, the diagnosis is made for completely incidental reasons. They go to the GP for a health checkup. They go to the GP to talk about something completely different. Liver tests are checked. The liver tests are abnormal, and that leads eventually to the diagnosis of PBC. But when symptoms occur, they will tend to be itching, fatigue, and dry eyes, dry mouth. Okay, So itching can occur at any point in the disease process. Usually it is at the beginning of the condition, and often it actually settles down as time passes. Probably because the URSO is working very well, potentially because of other treatments. But nevertheless, if you have PBC, if you don't have itching, then don't start to worry that it's suddenly going to happen. It doesn't usually happen like that. Okay. How many people in the room do have itching? Actually, let's get you involved a little bit. Okay, right. So there you go. So a good proportion of people do experience itching as a result of PBC. The next big symptom that people with PBC have, of course, is fatigue. Fatigue can be extremely debilitating, very, very incapacitating. And the real problem with fatigue, of course, is that whereas we have treatments for the itching, we don't have medical treatments for the fatigue. It often has a peripheral component, which means no energy in the muscles, no strength in the muscles. It also has a central component, which is that terrible brain fog. You just can't quite concentrate, have difficulty remembering, word finding difficulties. Subtle, not to the extent where you would say this is dementia, not to the extent where you would say this is hepatic encephalopathy, but nevertheless extremely troublesome. And the other big challenge, of course, with fatigue is that it can happen at any point in the condition. You know, the mildest liver disease all the way through to the most severe scarring of the liver. At any point, people can suffer from fatigue. How many people in the room experience fatigue from their PBC? Yeah, okay, so the majority of people, yeah. Yeah, no, it is a huge problem. And then, of course, the sicker symptoms, which is the dry eyes, the dry mouth, they can be very troublesome. And in some people, vaginal dryness as well. There's also a host of associated conditions. Okay, so Sjogren's syndrome is associated with PBC. Now, it's a little bit difficult to tease apart the dry eyes and dry mouth of PBC from Sjogren's syndrome. They do overlap to some extent. We would generally start to call it Sjogren's when the dryness of dryness of eyes, dryness of mouth was that much more severe. Raynaud's can occur. Raynaud's is a little bit difficult to describe, so I've included pictures of it, but basically it's you'll recognize it if you have it. It's when you go out into the cold and your fingers become painful and turn white. You know, if you leave them in the cold, they eventually turn blue and become very sore indeed. And then once you get out of the cold and are able to warm up your hands, the fingers turn bright red as the blood flow returns. Unusual phenomenon, but it does happen in about 25% of people with PBC. And as I say, you'll know if you've got it. Autoimmune thyroid disease is very common. And that's important because, of course, low thyroid, underactive thyroid can also lead to fatigue and tiredness. And then rare but important conditions such as systemic sclerosis and systemic lupus erythematosus. So these are all autoimmune phenomena, and about 50% of people with PBC will have another autoimmune condition. Again, show of hands, anyone else in the room with another autoimmune condition without telling us which one it is? Yeah, okay, so there you go. I mean, that's probably about half the room, isn't it? Yeah. And that again is because autoimmunity tends to run in families, it tends to run in individuals, and it's all down to how the immune system functions, and that mild error, which means that your immune system is no longer quite so good at distinguishing between self and non-self. Other important associated conditions, important because, physicians like me need to look out for these things. Osteoporosis. Osteoporosis means reduction in bone density. So again, difficult to explain exactly what that means. Therefore, I've included the picture there. On the left, you can see a normal bone, which has got which is porous. It's got those little holes in, if you like, so that it's not so heavy. In osteoporosis, those holes become much bigger and the overall density of the bone decreases. The problem with that, with osteoporosis, is that it means you're more likely to have a bone fracture. Therefore, we need to look out for it. And if we find it, we need to treat it. Okay, so again, bit of interaction. How many people in the room have osteoporosis? Yeah. Okay, so a few people, and I guess some of you will be receiving treatment to try and strengthen the bones. Okay, well, we can come on to what those treatments are. And then elevated cholesterol is the other thing that we look out for. Now, this really is a bit fiddly these days, actually. If you've got really severe PBC, which hasn't quite settled down on treatment yet, then the cholesterol can be very high indeed. But now that's not such a thing to worry about, actually, because that cholesterol is usually something called lipoprotein X, and lipoprotein X is not associated with increased risk of heart attacks and strokes. So if your cholesterol's high because of the PBC, it's not a problem. However, if the PBC is well controlled and your liver tests are looking pretty good, but you've got high cholesterol, well, it probably isn't lipoprotein X. It's probably the standard high cholesterol that meant that the general population has. That is the one that's associated with heart disease and strokes, and that is the one that needs treatment. So we have to look out for this in the clinic just to make sure that people get the treatment they need, and we don't deprive them of treatment because we blame it all on the PBC. Is that all making sense so far? Good. Just shout out if you have any questions, actually, because it gets a bit boring to just stand and talk. Yeah.
About the likelihood of diddling. Like 10%. And you said that the general, the general consensus was not for screening. However, although nothing's been diagnosed, when I explained what I had to my sister, she said, "Oh, I've got a lot of those symptoms as well." So I presume that in that sort of situation, it would be worth getting GP or medical, to have a screening for.
Definitely. If there are symptoms there, then for sure go and get those checked out. And as you know, and some people actually will want the screening anyway.
Yeah.
The point about the policy in current guidelines is that there isn't a system in place to ensure that all of the first degree relatives of a person with PBC are screened for the condition. But if the person with PBC is especially worried about their first degree relatives, and those first degree relatives on balance would rather know, then going to then for that person to go to their GP and ask for a liver test is a very simple thing to do indeed. And I think most GPs would not turn them away if they particularly wanted to know. So the point is that there's no formal policy in place, but an individualized approach is entirely appropriate according to the level of risk that people are comfortable with.
George, can I ask a question in that? Do you want questions at the minute or do you want questions at the end?
I'm happy with either.
Okay. So we have a question that's coming on the app, and hopefully people are using the app. And I've walked too far away to be able to read the question out. So the question is, does passive smoking also matter as a potential environmental factor?
Well, it's difficult to know. That hasn't been that has not been studied, I don't believe, although it's worth checking. I mean, I would presume that it does, given that PBC is more common in industrialized areas. It seems to be associated with heavy pollution, and it's certainly associated with smoking itself. So I would predict that passive smoking probably wasn't great for the liver. Remember that every toxin that you breathe in, that you eat, that you absorb through the skin, all of it has to be processed by the liver. So I would imagine that passive smoking isn't great. And, if we're going to encourage people to stop smoking, let's encourage everybody to stop smoking, not just people with PBC.
All right. Thank you, sir.
Okay. And then on to the complications. So I said before, what are we aiming for with PBC treatment? The real aim of treatment is to prevent cirrhosis from developing. And the reason we wanted to prevent cirrhosis from developing is because cirrhosis itself is complicated by a number of things, including portal hypertension, liver failure, and liver cancer. Okay. Now, what do I mean by portal hypertension? Well, the blood flow through the liver comes, 3/4 of the blood that goes through the liver comes from the intestine. It flows from the intestines through what's known as the hepatic portal vein into the liver. It then passes through the liver and flows into the inferior vena cava, and then flows back up to the heart and gets back into the rest of the system. Okay. Now, if you have cirrhosis, then it's very difficult for that blood to flow through the liver. And all of that blood that is coming from the intestines needs to find some other route back to the heart and into the rest of the system, into the rest of the circulation. So it begins to form channels, collaterals, usually in the stomach, in the esophagus, in the rectum. But these are not normal blood vessels. They have thin walls and they can bleed. So one of the problems with cirrhosis leading to portal hypertension and leading to these channels called varices is that they can bleed, and that can put people in harm's way. Now, does that make sense to anyone in the room? Has anyone in the room ever been told that they need to be screened for varices? Or indeed, has anyone in the room ever had problems because of varices? Yeah, there you go. So hopefully that all makes a bit of sense to you. Severe scarring of the liver means that the liver is not going to be able to function properly. It won't be able to keep up with the needs of the body. And when the liver is no longer able to keep up with the needs of the body, we'd say that that liver has begun to fail. A failing liver is characterized by things like jaundice, yellowness of the eyes, ascites, which means fluid inside the tummy, and hepatic encephalopathy, something I mentioned earlier, which is severe confusion that occurs in people with advanced liver disease because the liver is no longer getting rid of all of those toxins from the body. The toxins build up and begin to affect the way the brain is functioning. So we definitely need to avoid liver failure. And then the final major complication of cirrhosis is liver cancer. People with cirrhosis of the liver have a slightly higher risk of developing cancer of the liver than the general population. And that is the reason that in people with cirrhosis, we would generally offer surveillance in the form of regular ultrasound scans. Okay, so these are the complications that we need to avoid, and that's the whole purpose of treatment.
George, can I take you back just a step?
Mm-hmm.
How are Sika complex and Sjogren's syndrome different?
Well, as I said, it's very difficult to work out where one starts and the other, where one ends and the other starts. In general, we would very often see secondary Sjogren's, which is mild dry eyes, mild dry mouth in people with PBC, very common symptom. If it's severe, if it's associated with antibodies such as anti-Ro antibody, and if it's starting to, for example, affect the joints and have other manifestations, then we would probably say, okay, this is more likely to be primary Sjogren's syndrome overlapping with the PBC, and we would get a rheumatologist involved. But as I say, very difficult to know where one ends and the other begins. Okay, so that's what PBC does to the liver and what PBC does to the person. So knowing that, I'll just mention a couple of variant syndromes, because this will resonate with some of the people in the room. We sometimes see PBC associated with features of autoimmune hepatitis. In about 10% of people, there are also features of autoimmune hepatitis, which needs to be treated in a slightly different way. So I'm predicting 10% of this room will have PBC with features of autoimmune hepatitis. Do you want to give us a show of hands for that? Maybe not quite reaching 10%, but nevertheless, a small proportion of the room do have that. There is a portal hypertensive variant. So this is where the portal hypertension that I described a moment ago, the formation of those collaterals called varices, develops even before cirrhosis has started. That can happen in PBC. That can be complicated by bleeding from varices, but actually the good thing is that people with this portal hypertensive variant seem to tolerate that bleeding extremely well, which is reassuring. And then there's a premature ductopenic variant where the bile ducts are nipped off by the condition far more rapidly than you would expect. And the problem with this premature ductopenic variant is that although the liver is actually functioning quite well, the liver's keeping up with the needs of the body, you nevertheless get the symptoms of cholestasis, which tends to be extremely severe itching. So those are all variants, and various people in the room will recognize that they themselves have those variants, but it only affects a minority of patients. Okay, you had a question?
Hello, yes. I wonder if you could just advise me, the liver cancer that you mentioned, I know it's quite rare, but if you've got a comorbidity of already having had cancer, is the risk greater?
Of having which?
Well, I've got bowel cancer, but I wondered whether the liver cancer is more prevalent because of that.
No. So that would not be, no. So the risk in people with PBC comes entirely from the cirrhosis. Yeah, there are certain cancer syndromes, but that would not be one of them. Yeah. Okay, so the next discussion point or introductory point is how we treat PBC. So this we'll come back to in one of the breakout sessions tomorrow, which is the BSG, British Society of Gastroenterology's care pathway. But I'll just quickly mention that once we have a diagnosis of PBC, the care pathway really falls into these three pillars: treatment and risk stratification, and we'll discuss that in a second, staging and surveillance, and we'll be discussing that as well, and then actively managing, which really boils down to just making sure that all of the symptoms of the PBC are covered as well. Okay, but how do we make that initial diagnosis? So again, this will resonate with many of you in the room because you will have yourselves been through this journey. But the diagnosis of PBC really hinges on identifying two of these three criteria. So people are going to have abnormal liver tests, okay, usually persistent elevation of the alkaline phosphatase. They'll have some more specific blood tests, specialized blood tests, which will show that they have specific autoantibodies, antibodies which are not normally present, but are present in autoimmune conditions. And in the case of PBC, those diagnostic autoantibodies are the anti-mitochondrial antibody, present in about 90% of people. Have you all heard of the anti-mitochondrial antibody? Yep, so that all makes sense to you. And less, in about 50% of people, some specific anti-nuclear antibodies, namely anti-SP100 and anti-GP210. So in most people, in 90% of people, the diagnosis will be based on that combination of having the abnormal liver blood tests followed by the detection of one of these autoantibodies. In a proportion of people, though, a liver biopsy is required to confirm the diagnosis. The two main indications for liver biopsy being where you suspect it's PBC, but the antibodies are not present. And under those circumstances, the only way you're going to make the diagnosis is by doing a biopsy. Or when you've worked out that it is PBC because of the blood tests and the antibodies, but you suspect that you might have one of those, you'd be looking at one of those variant syndromes, the PBC with features of autoimmune hepatitis. And the only way to make that diagnosis would be by doing a biopsy. But the majority of people won't need one. So if you haven't been offered, you're not losing out. And I certainly wouldn't have one if I didn't need it. So yeah. Occasionally these days, it's a little bit difficult to work out whether people have got just PBC or whether they've also got PBC and some other condition, usually fatty liver disease. So these days we're seeing more biopsies to try and work out whether there's also fatty liver disease and whether that could be the predominant pathology. That's a growing indication. But as I say, the main reasons for doing the biopsies are diagnosis of antibody-negative PBC and diagnosis of autoimmune overlap. Any questions related to those diagnostic tests or biopsies?
So
no.
I'm going to ask that question again, just for the people that are online. Question was there any link between severity of disease and the number of antibodies? No, there doesn't appear to be, actually. People with the antibody-negative PBC, their condition seems to behave in pretty much the same way. The anti-GP210 might be associated with a more severe form, and it might be associated with the overlap form. But for anti-mitochondrial antibody, the level of the antibody, the presence of the antibody, this doesn't seem to be to affect the severity of the disease.
I have two questions. My name's Emma. I'm a medical biochemist and just training as a psychotherapist and counsellor, so two-pronged. And until recently, I was the global patient officer at Ipsen. So I have two questions. One is around sicker complex. You said that the prevalence of symptoms was 80% for itch, 50% fatigue. Sicker complex is another common symptom. Do you have a percentage for that?
No, but there will be. I'm sure we could find
Okay.
a proportion.
And then my second question is more towards mental well-being.
Mm-hmm.
So are there any data that show the association between the diagnosis of PBC and anxiety, depression? Are there any aligned mental health data?
Yeah, there are data on that. So people with severe symptoms do have significant reduction in health-related quality of life, and sometimes that reduction in health-related quality of life is sufficiently severe that it begins to become depression and anxiety. So for sure, these symptoms can be so severe as to have additional mental health consequences. Yeah.
Thank you. Are you happy with a couple of questions just about what you've said? So kind of more follow-up. I'm saying but should we be tested for lipoprotein X to avoid having to take statins?
I mean, it's a good question. And if somebody had significant elevation of cholesterol in the context of severe cholestasis, high ALK phos, then you would do more specialized testing. It's not a routine, lipoprotein X is not a routine test by any means. So the majority of hospitals will not be able to offer that. There are other ways of getting around that. You can look for apoprotein B and so on. But again, this would tend to be done in a specialized lipidology service. So I think the answer from a practical perspective is no. And you can really make the decision from a clinical perspective. You can be guided by the severity of the cholestasis. So what's the alkaline phosphatase and what's the bilirubin and the cholesterol? As I said before, if all three are very high, then it's probably the lipoprotein X, and you probably then do want a lipidologist involved. But if the alkaline phosphatase is only slightly elevated and the cholesterol is, say, 7, then it's probably going to be the type of elevated cholesterol that we see in the general population, the one that needs statins, and it's best then to be on the statins.
Okay, perfect. Thank you. And I think what might be the last question, because we're coming down to do a Q&A specific session shortly. Now, industrial pollution in China, that's a whole conversation. But then China has the lowest recorded PBC rate. So do you think that's due to lack of information or due to lack of PBC?
No, actually, I think what we will see is that as China becomes more industrialized, that the rates of PBC will increase accordingly. And in fact, there is some epidemiological evidence to suggest that exactly that is happening. Yeah.
All right, perfect. Thank you.
Okay, so I just want to get on to monitoring of PBC because this is relevant and something that you need to remember when you go home after this conference. So most people with PBC are going to be offered a clinic appointment every 6 to 12 months. It doesn't have to be every 6 to 12 months. Occasionally, the PBC is so well controlled. Oh, what's happened to the screen? Great. Okay. It doesn't have to be that. Occasionally, as I say, the PBC is so well controlled that actually the physician will decide every 2 years is adequate. But generally, it's going to be every 6 to 12 months. And sometimes if the symptoms are very difficult to control, it's going to be more often than that. Blood tests are going to be done generally, again, as I say, every 6 to 12 months. That will almost certainly include the liver tests. Okay. So the liver tests are the bilirubin, the transaminases, the ALT or AST, the alkaline phosphatase, and the albumin. Okay, worth remembering these names. These are all very relevant to people with the condition. And the blood tests will very often also include the kidney tests, the full blood count, and the blood clotting. And I just wanted to highlight here why knowing your alkaline phosphatase and your bilirubin is so relevant. So these graphs come from huge studies involving thousands of patients. You can see there at the top, 4,500 patients who were followed up over the course of time until they reached some kind of endpoint. And the point to take away from these graphs, if I just show you the ones on the left, is that if you look here, this is the alkaline phosphatase, the relationship between the alkaline phosphatase and the likelihood of having a liver. Yeah, okay. I might need someone to come and show the graphs in that case. But anyway, basically what the graphs show is the relationship between the level of the alkaline phosphatase and the likelihood of the patient eventually having some kind of outcome from the PBC, a complication such as liver failure, bleeding from varices, needing a transplant. And you can see that there's what we would call a linear relationship, meaning that the higher the alkaline phosphatase at any given point, the more likely the person is to eventually have one of those end-stage events. All right. So if the alkaline phosphatase is running very high, that means the PBC is not adequately controlled, more likely to progress to cirrhosis, more likely to cause complications. And that's the reason that it's so important that actually that you also know these blood results. Okay, because then you'll have a sense about how well the disease is controlled. Monitoring also consists of lots of scans. Okay, I've included pictures so you know what I'm talking about. Many centers these days will offer a regular fibroscan. Okay, so you've heard about fibroscans. Someone is going to be offering fibroscans today. So you can go and have one if you've never had one before. A fibroscan basically involves putting a probe onto the side of the chest in the liver area. That probe creates a vibration, which then passes through the liver. And the speed with which it passes through the liver gives you a sense of how much scar tissue there is inside the liver. A very helpful measurement. Tells you whether there's cirrhosis, for example, or not. It enables you to track the rate of progression of the liver disease by repeating the fibroscan at intervals. Okay, so this is a very useful test. And as I say, more and more centers are offering it. Quick show of hands. How many people have already had a fibroscan? Good, that's great, that's excellent. If people have developed cirrhosis, as I said before, there is a slightly higher risk of developing liver cancer as a complication of that cirrhosis. It's not a very high risk. It's not enough to be panicking about, but it is high enough to justify looking for it at regular intervals. So in people who have developed cirrhosis, we would generally do an ultrasound scan of the liver every 6 months. I mentioned before that one of the complications of cirrhosis is developing portal hypertension. And if people have got portal hypertension, they might suffer from bleeding from varices. So if we suspect that people have got portal hypertension, if we think they're at risk of having those varices, then we would very often offer an endoscopy, a camera test of the stomach to look for those varices. And if we detect them, then we can give treatment to reduce the risk of bleeding from them. And you'll also remember that I said that people with PBC have a higher risk of developing osteoporosis. So if using scoring systems such as the FRAX score, we work out that someone is at risk of osteoporosis, then we would generally offer a DEXA scan. So do all those scans resonate with you? You've all had something along those lines. That's good. All right. And then the final section is just on treatment. Okay. So starting with disease-modifying treatment, these days currently we have a stepwise approach to the treatment of PBC. And what that means is that everybody starts with ursodeoxycholic acid. Ursodeoxycholic acid is a bile acid. It's actually a naturally occurring bile acid. The reason there's a picture of a brown bear there is because it's present at a very high concentration in bears. And indeed, it has been used, bear bile was used as a remedy for many thousands of years. We don't get it from bears any longer, of course, but nevertheless. Optimal dose, as you all know, 13 to 15 milligrams per kilogram per day. How many of you know what dose you're on in terms of your weight? You mostly know, okay. Are you all on the correct dose? That's excellent, okay. This is an improvement compared to many years ago. It's generally very well tolerated, actually. So most people will experience some weight gain, about 3 kilograms worth of weight gain in the first year of treatment, and then that just settles down. Some people very rarely will get thinning of the hair. Occasionally, it can cause some GI upset, gastrointestinal upset, a bit of diarrhea, and that's usually the limiting factor, actually. If people do experience bad diarrhea, that's generally the reason they can't take it. But most people tolerate it very well. How many people are taking ursodeoxycholic acid? Yeah, okay. But there are a few people who haven't raised their hands, and I guess that's because they didn't tolerate it. Now, it's an excellent treatment, and the reason that we use it as first line is because if it was worked out quite some time ago that if the liver tests settle down with ursodeoxycholic acid, if people have an adequate urso response, then in fact their survival from the PBC is equivalent to that of someone who doesn't have the condition. All right. So if your liver tests are looking good with urso, then your prognosis from the liver disease is excellent. All right, which I hope will be reassuring to you. Right. About 25% of people, however, do not see that adequate urso response. So their liver tests may improve, but not enough for us to feel really comfortable with that. People who have an inadequate urso response will very often have ongoing disease progression, higher risk of developing cirrhosis with all of those complications we've talked about. So for those people, we would offer second-line treatment. And there are two commonly used second-line treatments available currently. The first is obeticholic acid, which in technical terms is an FXR agonist. It improves the flow of bile through the liver and helps to reduce inflammation accordingly. And the second are the fibric acid derivatives, bezafibrate and fenofibrate, which are, in technical terms, PPAR agonists, which also have this effect of improving the rate of flow of bile through the liver and helping to settle down the inflammation accordingly. In most people, they're effective and they're well tolerated. A couple of issues with obeticholic acid, though. It can, under some circumstances, worsen itch. That tends to worsen itch in people who have already got problems with itching. So very often, if we want to use obeticholic acid, we will have to get that itch well treated first. And once it's well controlled, then people get on okay with it. And it's best avoided in people who already have decompensated liver disease. So if the cirrhosis has already reached the point of liver failure, it's probably best to avoid the obeticholic acid. Has anyone ever tried obeticholic acid? Okay. And how did you get on with it? Yeah. Yeah, good. Okay. And that's what we'd hope for, and that's what we'd expect. All right. Fibrates, again, they are generally well tolerated. They are effective. They can really affect the kidneys, though. They can cause a kidney injury in some people. So best avoid in people who already have a kidney injury, and they do require fairly close monitoring when first started. There will be a proportion of people who don't get on with urso, and who can't, for whatever reason, take the obeticholic acid or the fibrates. Unfortunately, there are some new drugs on the horizon, and I'm sure you will hear more about those today, which we can offer under those circumstances. Mm-hmm.
They decide whether you go on obeticholic acid or a fibrate?
In the UK, this tends to be decided by a team of people, a multidisciplinary team, and that will generally consist of a physician, a pharmacist, and a nurse as a minimum. And it'll be determined based on the presence of itching, the stage of the liver disease, and the kidney function. Those will be the main factors that influence the decision. Yeah. If there's itching there, you might opt for the fibrate. If there's a kidney problem, you might opt for the obeticholic acid. Okay, so it's not just about treating the disease, of course. We also need to treat the symptoms. And I'll just touch on itching because I think we're probably beginning to run over time. Firstly, moisturizers do help. So anyone who does have itching, use regular and liberal use of moisturizers can be very helpful. But the usual treatments that we would adopt would be something called Questran. Anyone in the room tried Questran before? Yeah, okay. So it's not the nicest drug to take. It comes as a powder. You've got to make it up into a drink. It never dissolves completely. It always tastes a little bit pasty, but it does usually work pretty well. So if people can persevere with it, they do often get a decent response. The other complication, though, apart from being fairly unpalatable, is that it's quite a fiddly drug to take. You've got to take it at least 3 hours separately from any other medication to make sure that it doesn't bind those other medications and prevent them from working. If it doesn't work, or if people just can't get on with it, then the other drug we would tend to use is rifampicin. Again, slightly fiddly drug. It can sometimes cause a liver injury, so it needs fairly close monitoring, and we wouldn't want to use it in somebody who's got advanced liver disease. And then the rest are just not really quite as good. So we can usually get on top of things with this combination of Questran, rifampicin, sometimes the fibrates, but we certainly need newer drugs for treatment of itching. And again, that's going to be something that that the GSK representative will be talking about throughout the course of this conference. Fatigue, as I said before, very, very difficult, as many of you will know. Unfortunately, we don't have medications that we can use for treatment of fatigue. If it is severe, it's very important to look out for other contributory factors. So does the person also have itching? Could the itching be affecting the sleep quality? Would treatment of itching therefore improve the quality of sleep and improve the fatigue? Worth checking the thyroid function, because hypothyroidism worsens fatigue. Look for celiac disease, look for anemia, look for diabetes, and so on. So there's a host of other things that we ought to look for when people have fatigue. Very often we don't find anything else though, and the fatigue is entirely down to the PBC. And then it, I'm afraid, boils down to lifestyle adjustment, and that can be very, very challenging. Modafinil is useful for some people. Modafinil is a drug which is rarely used, though, for excessive sleepiness. So if the fatigue is characterized by no energy in the muscles and brain fog, but not by excessive sleepiness, then modafinil is probably not going to be effective. And then the sicker symptoms are entirely, this is entirely symptom-based treatment. Artificial tears for dry eyes, artificial saliva sometimes for dry mouth, but usually people get on with sips of water, sugar-free mints, sugar-free chewing gum, and vaginal moisturizers as required. And finally, liver transplantation. So occasionally, the medications don't work. And people unfortunately do develop cirrhosis with complications of cirrhosis. Liver transplantation is an excellent treatment under those circumstances. It is, however, a major operation. It's an operation that can last greater than 12 hours. It's followed by lifelong immunosuppression. It comes at a cost. There's a 1 in 20 chance of dying because of the transplant within 1 year, 1 in 5 chance of dying because of the transplant within 5 years. So we would never rush into doing a liver transplant, and I'm sure everyone in the room appreciates that. Very much a treatment of last resort. But the people who have them, I'm sure, will testify that it is an excellent treatment, and their lives are transformed. In PBC, the indications, the standard indications for transplant would be liver failure, liver cancer, and very occasionally where we just cannot get on top of the itching. Intractable itching, where people have very, very severe reduction in their quality of life. The medications aren't working, and the only option under those circumstances is to simply replace the liver. Okay, so we've touched on all of these things. I hope that all made a lot of sense, and that you could contextualize your own experience of PBC. I hope it'll have simulated a few questions, and we can perhaps do those now. But in addition, I hope that it'll have prompted some thoughts that you can take away to the various breakout sessions, which will be for the rest of the conference.
Wonderful. Ladies and gents, Dr. George Mells, thank you so much.